Good morning. Thank you, Needu. I'll be talking about challenges in the clinical diagnosis of uveitis. The management of uveitis is often challenging. Why? Because all these posterior uveitis entities looks very much similar, but they all have different etiologic diagnosis. Similar etiologic diagnosis can have different presentation, different clinical presentations also. And moreover, after all evaluation, 1/3 of patients, we won't be able to find out any clear etiologic diagnosis also. So what to do? The right protocol can prevent permanent vision loss. I'll show you some examples. This is a case of granulomatous anterior uveitis with mutton fat KPs and Busaka nodules on iris. So rule out TB and sarcoidosis in this type of uveitis. See another granulomatous looking lesion, but we can clearly see a mature cataract behind. So it's not a uveitis per se, it's a lens-induced AC reaction with lens deposits. Yet another patient, granulomatous looking lesion, but see carefully, there is no much KPs and AC reaction. All these are deposits on iris. So it was a case of iris metastasis from lung small cell carcinoma. These three are mild non-granulomatous anterior uveitis. But in the first case, it was first presentation in a young doctor. On clinical, on detailed history taking, he gave history of treatment for tubulointerstitial nephritis 1 year before. So that was a recurrence. He had high beta-2 microglobulin. In the second patient, looking carefully, can see stellate KPs, secondary cataract, and absence of posterior synechiae. So that was a case of Fuchs. In the third patient, she had undergone surgery for CA breast and taken 1 dose of injection zoledronic acid 1 day prior. So that was a case of drug-induced anterior uveitis. Now these three hypopyon anterior uveitis cases. Look at the first case. This patient gave history of recurrent episodes on both eyes with neck stiffness and morning stiffness. So it's a clear-cut case of HLA-B27 associated anterior uveitis. In the second patient, again having hypopyon, shifting hypopyon with vitritis, and on evaluation had mouth ulcers. So it's a case of Behçet. Third patient, again hypopyon uveitis, acute onset with a history of septicemia. So it was an endogenous endophthalmitis. Now coming to intermediate uveitis, this young engineering student, healthy male, presented with intermediate uveitis like picture. All initial evaluation were within normal limits, but on careful examination could see some exudates floating in the periphery. Again asking questions, he gave history of IV drug abuse. So that was a case of endogenous endophthalmitis again. This patient again was treated as intermediate uveitis before with systemic steroids and no improvement. See on detailed fundus examination shows a peripheral toxo lesion. So examination of the eye as a whole is also very important. See, these are whitish lesions in the posterior pole. But in the first picture, it's a deep lesion. The margins are not well defined. Vessels are clearly seen. No much vitritis associated. So it's a choroiditis. Always rule out TB sarcoid in these patients. And second picture, it's more superficial, associated with vitritis. Vessels are not very clearly seen over it. Margins little more well defined. So it's a case of toxo-retinochoroiditis. Look at these white dots in the posterior pole. First, in the first photo, it's not associated with vitritis, deeper lesions. These are all choroidal granulomas associated with sarcoidosis. In the second picture, more whitish dots, again deep choroidal, associated with disc edema. it's a suggestive of white dot syndrome. In the third picture, the white dots are more superficial retinitis lesions associated with the disc edema and vasculitis here and there. So on careful examination, you can see the dots arranged very clearly in a pattern. So that was a case of DUSN. Now look at these photos. All looks very much similar with cotton wool patches and hemorrhages. But in the first two, bilateral vasculitis, patient had CME with occlusive vessels, and patient had this malar rash. So diagnosis is easy. It's SLE associated occlusive vasculitis. In the second set, patient was again young with a high BP, so that was hypertensive retinopathy. See these two vasculitis, any difference between these two sets? In the first picture, more of veins associated, periphlebitis in a young healthy male. So that was Eales disease. In the second set, associated with vitritis, vasculitis involving both arteries and veins, associated with disc edema and some retinitis patches here and there. So that was Basage. See this photo, it's not retinitis, it's not choroiditis also, some deep retinal lesions. While asking detailed history, he gave history of multiple sexual partners, and he also had genital lesions before, so that was a case of syphilis. Again, one pan uveitis, one eye involved with pan uveitis. Look at the other eye, shows history of old history, trauma patient. So it's a case of sympathetic ophthalmia. Look at these two images. Both looks very much like posterior scleritis, but no much inflammation. In the first photo, more of quiet fluid, and can see one mass underneath. This was a metastasis from CA breast, and the second patient was not having much of fluid detachment. It's a mass pushing from behind. So that was a case of CA lung, adenocarcinoma lung with choroidal metastasis. These two photos looks like toxo reactivation, but in the first picture, no vitritis at all, hemorrhages associated with that reactivation looking lesion. So that was secondary CNVM associated with toxo scar. In the second picture, associated with inflammation, vitritis, vasculitis. So that was toxo reactivation. So what is the key for a proper clinical diagnosis? Detailed history, meticulous head to foot examination, and a thorough ocular examination including indirect ophthalmoscopy. And keep in mind the eyes will see, only the mind knows, so keep updated. So with good clinical diagnosis, we can reduce the investigations needed, reduce the imaging tests needed, and we'll get the proper diagnosis earlier, can start the treatment earlier, so that can avoid a vision loss. Thank you.
Thank you, Dr. Reesha. That was a wonderful talk and wonderful collection of the cases and the photographs.